Hello, and welcome to this workshop series, Preparing for the New Era of Blood-Based Biomarkers and Alzheimer's Disease, Navigating Guidelines, Policy, and Practice Workflow Integration. I'm Suzanne Schindler, Associate Professor of Neurology at Washington University School of Medicine, and today I'm happy to have Greg Day, Associate Professor of Neurology at Mayo Clinic in Jacksonville, Florida, join me for Workshop 1 so that we can talk about the science and the promise of blood biomarkers in Alzheimer's disease. Welcome, Greg.
Thanks, Suzanne. Glad to be here.
Thank you to PeerView for providing this session and to Lily for providing the educational grant for this symposium. As a reminder, look out for additional polling during the presentation. Submit your questions and we will answer them in the chat. The slides and practice aids can be accessed in the activity menu now and downloaded after the session. During today's workshop, we will learn that recent advances in blood-based biomarker testing have greatly expanded access to minimally invasive and cost-effective tools that support early and accurate diagnosis of Alzheimer's disease. And these blood-based biomarker tests can accurately predict brain amyloid pathology and correlate with cognitive decline and dementia risk in Alzheimer's disease. So let's start off with a case. Margaret is a 68-year-old woman who recently told her primary care provider that she and her husband were both getting concerned about her forgetfulness. Her memory lapses have become more frequent over the past year, but she was able to manage it by leaving reminder notes for herself. Her primary care provider performed a clinical assessment, including a patient and family interview, medication review, neurological screen, MoCA, and some basic lab work. Based on her self-reported cognitive symptoms, which were corroborated by her husband, her MoCA score, which was 24 out of 30, was only 1 out of 5 on verbal recall. The absence of impairment in basic or instrumental activities of daily living and lack of other remarkable findings, Margaret's primary care provider diagnosed her with mild cognitive impairment, or MCI, and the underlying cause of her symptoms was presumed to be Alzheimer's disease. Margaret's primary care provider gave her a referral to neurology so that she could undergo biomarker testing to determine whether Alzheimer's disease pathology is contributing to her cognitive changes. However, she lives in an area where the wait list for a neurology appointment is 18 months long, and the nearest PET imaging center is 3 hours away. So her primary care provider decided to order blood-based biomarker testing. Greg, what do you think about Margaret's case?
Yeah, great question, Suzanne. I think any of our listeners who routinely see and assess patients with memory and thinking problems are going to recognize this case. This is a woman in her 7th decade of life, 68 years old, with an amnestic predominant difficulty with memory and thinking that's evolving over the past 1 year. It's not overall affecting her function, so she's maintaining a lot of performance in important areas, but it's definitely a change from before and definitely worth recognizing, requiring further evaluation. Ultimately here, I think her primary care practitioner has it right. Reasons to be concerned, plans for investigation, and importantly, a potential diagnosis of mild cognitive impairment or early symptomatic Alzheimer's disease. And identifying that Alzheimer's pathology is going to change the course for this patient. So she needs further testing, but like many patients in our country, has a long wait to get it and can't exactly access advanced biomarker testing easily. I think this really gets at the heart of the matter and why we're interested in exploring the applications of blood-based biomarkers here. Our patients want not just a diagnosis or acknowledgement of their problem, saying you do have a memory difficulty. They want to know what the cause of that memory problem is and want to act on that. And they'll tell us that. Go ahead and ask your patient next opportunity you have. But this answer, the ability to receive an accurate and early diagnosis, validates their concerns. They know there's a problem. They're not going to be surprised to learn that. But it also, and maybe most importantly, enables our patients to participate in their own care planning at a stage of the illness where they maintain capacity, the ability to integrate information, and plan for next steps. This also empowers patients and their family members to make lifestyle changes, to enact important decisions that maybe might slow progression of the disease, may help manage comorbidities, and ultimately improve their longer term brain health. And of course, it facilitates access to education and personalized support services for patients and those that care for them. Biomarker confirmation, as you and I both know, is definitely required when we're thinking about disease specific therapies. And I think that's really what's changed over the last few years has been the emergence of these therapies, particularly anti-amyloid therapies, that are options for our patients with early symptoms of Alzheimer's disease. But to access those therapies, we need to know that the cause of their symptoms is due to Alzheimer's disease changes. And even more importantly, as we look forward to new and future therapies, we want to be sure that we're enrolling patients with a disease, a target disease, in the right clinical trial. So, when we talk about Alzheimer's disease, we recognize that this is a disease that actually starts even decades before symptoms first begin. The buildup of amyloid plaques, according to the leading hypothesis, leads to a change in the tau proteins in neurons, resulting in tau tangles. That's our blue line here, which seems to be closely related to the onset and progression or emergence of neurodegeneration, loss of neuronal structure, neuronal function, and then followed by the emergence of cognitive symptoms. Currently, we have a number of different biomarker measures that we can apply to recognize patients with changes in the brain related to Alzheimer's disease. Our gold standard, best tested one, probably our amyloid PET imaging and increasingly tau PET imaging as well over the past few years. But we can also directly measure changes in spinal fluid, so the fluid that bathes the brain, looking for changes related to the Alzheimer processes. That would be differences in amyloid beta levels, usually those are a little bit lower, and elevations in levels perhaps of phosphorylated tau isoforms that may mark changes related to neurodegeneration or the onset of neurofibrillary tangles. And increasingly, what we're talking about today, blood tests that offer the potential to measure Alzheimer changes through more accessible, widely available testing. Clinicians and patients, though, ultimately want broader access to tests. And that is the potential here, the prospect of blood-based biomarker testing in the era of increasing access to disease-modifying therapies for Alzheimer's disease. Blood-based biomarkers may be the only modality that will enable adequate volumes of testing to meet the needs of patients across this country, including patients like Margaret who are in areas where it's not very accessible to show up for a PET scan or a lumbar puncture. The benefits of blood based biomarkers, well, there are a few others as well. Not only are they potentially more accessible, but most people are going to consider them less invasive. We've all had a blood test, we're all relatively comfortable with that procedure. If used appropriately, they may be less expensive, and they may be more acceptable to patients as a testing methodology than a lumbar puncture or an amyloid PET scan. In theory, they can also provide better access, broader access to new therapies by promoting triage right at the level of primary care and ultimately reducing wait time for follow up biomarker testing if required or additional evaluations needed to qualify someone for anti amyloid therapies. The current indications, who are we going to use these tests in? Well, ultimately, these tests are not a replacement for a clinical evaluation. And so we're going to reserve these tests for patients who are undergoing an evaluation and who have objective evidence of cognitive impairment. That's going to be evidence that comes from a reliable collateral source like Margaret's husband or that bedside cognitive testing, or ideally both of those things. We're really not recommending these tests, not planning to use them in those who are simply worried or want to know what their future risk is, those cognitively normal individuals who might be at risk. And so I'm going to restrict them to patients who I think Alzheimer's disease is the cause of their cognitive impairment and who the results of these tests may actually change their management, either by improving the accuracy of a diagnosis of mild cognitive impairment or dementia, and or by determining which patients may benefit from disease-specific therapies. Before we move on, please take a moment to answer a follow-up question on biomarker testing. Suzanne, now I'll pass it back to you for an evaluation of the evidence supporting the use of blood biomarkers for Alzheimer's disease in clinical practice.
So, right now in clinical practice, there are a whole array of blood tests for Alzheimer's disease that we can order today. And these include tests that are listed in this slide. They come from a variety of different companies. And there's a variety of different biomarkers that can be used, including the ratio of A beta 42 to 40, p tau 217, as well as p tau 181. There are other tests as well. So it's wonderful that we have all of these tests available. But of course, when we have a long menu, the question is which test should we order? Which one is most appropriate? And I think the diagnostic companies are trying to be helpful. So you may see information like this on their website. And the way that this is sometimes described is that plasma amyloid 42 to 40 is most related to amyloid. Phosphorylated tau at position 181 is most related to tau, and neurofilament light chain is most related to neurodegeneration. However, there are concerns about this framework. If we think about this from a scientific point of view, really what they're doing is providing hypotheses. And this shows the hypothesis that we think that 42 to 40 is most strongly associated with amyloid, p-tau 181 most strongly associated with tau, and NFL most strongly associated with cortical thickness. And there's another implication as well, which is that the combination of multiple biomarkers is better than one biomarker. This seems intuitive, but is this really correct? Well, we did a large head to head study of some of the leading tests for Alzheimer's disease pathology, and the results were not really as some might have predicted. What we found is that tests or combinations of tests that include p-tau 217 are by far the best, not only for tau pathology, but also for amyloid pathology, cortical thickness, which is related to neurodegeneration, and cognitive impairment. So all of these tests with the arrows are showing you different measures that include p-tau 217, and you can see uh, that these are the best performing. A couple points that are important here. So the dashes in blue are amyloid beta 42 to 40, and you can see that all of those 42 to 40 tests are significantly further to the left. That is, they're performing worse in classifying amyloid PET status. So it turns out that no, A beta 42 to 40 isn't the best for determining whether someone has amyloid pathology. It's really p-tau 217, those green dashes. The p-tau 217 measures in green again are the best at determining whether someone has tau pathology. The previous framework was suggesting that neurofilament light, shown in maroon, would be the best at determining whether a patient has atrophy, brain atrophy, as shown by smaller cortical thickness or by cognitive impairment. Again, that's not what we see. We see that p-tau 217 based measures in the green are doing the best for determining whether someone has neurodegeneration or cognitive impairment. So what we see is actually much simpler than what you might expect, and that is that p-tau 217 based tests are the best for determining whether individuals have all of these Alzheimer's disease related pathologies. An additional point is that if you combine these various tests together, say that you combine together p-tau 181, A beta 42 to 40, GFAP, and NFL, all of those together, they're still not as good as p-tau 217 by itself. So this is why in my clinical practice, I only use tests that include p-tau 217. Now, sometimes they include other analytes as well, but I think that p-tau 217 is by far of the tests that are currently clinically available the best measure of whether a patient has Alzheimer's disease pathology or not.
Now, on the topic of p-tau 217, let's talk about its applications. We're talking about it in our own specialty practices, but we have some additional data that shows that other measures of p-tau 217, in this case, percentage of p-tau 217, when combined with plasma ratios of A beta 4240, seem to improve diagnostic accuracy in other clinical care settings. In this case, looking at data from primary and secondary care settings. I think the key thing to recognize here is that both groups improved. What we're seeing here is the blue dots. Well, if we're looking at the ones on the left side of the screen, that's the accuracy of dementia specialists. When we said something was due to, or cognitive symptoms were due to Alzheimer's disease, what was our accuracy, positive predictive value, negative predictive value, sensitivity, and specificity? We can compare that to our colleagues in primary care. And what we should recognize is that while we're both doing an okay job, neither group is doing a great job when we're relying only on our clinical history alone. Now look instead when we start to integrate markers of p-tau 217, either individually or in combination with the A beta 4240 ratios. And now we're seeing the dark navy blue dots and the orange dots moving much towards that accuracy we all want to achieve and equalizing performance between secondary care and primary care practitioners. I think a really valuable addition to the literature and certainly helpful for our patients who are seeking that accurate diagnosis in both of these settings. Before we move on, please take a moment to answer a follow up question on blood biomarkers for Alzheimer's disease. Now, what else can we use plasma p-tau 217 for? Well, we're talking about how good it is at recognizing patients with symptoms, impairment due to Alzheimer's disease, but it's also good at discriminating those patients from patients with other causes of cognitive impairment, and perhaps performing even better, or at least as well as some of the other markers that we have, including spinal fluid and imaging biomarkers of disease. And what we're showing here with this ROC analysis is that plasma p-tau 217 can differentiate Alzheimer's disease dementia from non-AD dementia with similar performance. However, even in patients who are amyloid positive, Alzheimer's disease may not be the driving force behind cognitive decline. And so, what that means is that a positive test tells us only about what's present in the brain. There may be Alzheimer's disease changes. It doesn't tell us about what else might be present in the brain. So, a patient can have Alzheimer's disease and vascular disease. That would be very common. Can have Alzheimer's disease and Lewy body disease, or even Alzheimer's disease and other changes related to frontal temporal lobar degeneration. And so we need to be mindful of that a positive test here just tells us about the presence or absence of Alzheimer's disease. It doesn't exclude the possibility that other pathologies, other changes are also present as well. And I think really important to emphasize that Alzheimer's disease is an age related disorder. So the prevalence in our population goes up as patients age. And so a lot of older patients, particularly those above age 75, are going to have amyloid changes in the brain simply related to their age and may not reflect the actual cause of their cognitive symptoms. And so we need to be really careful in whom we're performing this testing in. I'll argue that in older patients, those over 75, certainly those over 80, a positive test doesn't necessarily give me a lot of the information that I need. A negative test, however, is more helpful, suggesting that Alzheimer's disease changes are unlikely to be present in older patients. That's my take on it, but Suzanne, I welcome your thoughts about how you interpret these tests in older patients.
Greg, I completely agree with you. So, a really key concept is considering the pretest probability of amyloid pathology, which is very high in older patients. And it's actually rather challenging to think about what the cause is of cognitive impairment in older patients, especially patients like the ones that we see that who often have multiple potential causes of their cognitive impairment. And it's really important that clinicians not just get a positive p-tau 217 test and attribute all of the symptoms to Alzheimer's disease. It's really important that even when Alzheimer's disease is present, that clinicians continue to evaluate for other potential causes of cognitive impairment that may be reversible. So, for example, treating mood disorders, trying to discontinue medications that may be contributing to cognitive impairment, looking for sleep apnea, looking for cerebral vascular disease or other medical conditions that could be contributing. So, that's a really key part of using these tests appropriately is even in the context of a positive test to keep looking for other etiologies that are contributing to cognitive impairment.
Yeah, more great practice points. Thanks for sharing. Well, a little bit more on how we interpret blood based biomarkers, putting into practice the words of advice and things that we're talking about today. And so I think here it's really important to know if we order a test, we're going to order it in the right patient. And we may want to consider other factors that could affect or influence the performance of that test. And I think a key point here is that there are a number of other comorbidities, other health system challenges that might influence the likelihood of a positive test or a negative test, influencing the sensitivity and specificity. Chief among these is chronic kidney disease. And that's highlighted about the midpoint of this figure here. But in particular, renal failure, low EGFRs seem to result in false positive or increased levels of these biomarkers in the blood. And so we want to be really cautious when we're interpreting these tests in our patients who may have kidney disease. Other factors may play a role as well, including BMI, history of smoking, history of stroke, particularly acute or recent stroke, and myocardial infarction, may all affect levels of plasma 181 and plasma 217 as well, even after we adjust for other factors going on. And so, for this reason, when we're ordering this test, we want to be thinking about are we ordering it in the right patient? And I'll argue that when we're ordering it, we should also be ordering creatinine and an estimated glomerular filtration rate so that we can accurately determine and accurately interpret this test result in the individual patient. Suzanne, I'm going to hand it back to you to explain why it's helpful for us to use a two cut point interpretation of these biomarker tests rather than a single positive or negative.
Thanks, Greg. So, as we talked about when we were discussing the physiology of Alzheimer's disease, the biology of Alzheimer's disease, it's not that one day you don't have Alzheimer's disease and the next day you do. Alzheimer's disease pathology accumulates over many years. And because of that, there's a significant number of people who are near the cutoff. They have maybe a little bit of Alzheimer's disease pathology, but not enough that we would think it could contribute to symptoms of cognitive impairment. So, this is one reason why we think a two cutoff approach is appropriate for clinical care. So, the basic idea is that you have a high cutoff. And so that if someone has a biomarker level above that cutoff, you can feel very certain that they are positive and that their symptoms could be related to this Alzheimer's disease pathology. On the other hand, if someone has a very low level, below the lower cutoff, you can have high certainty that they're negative, that they don't have this Alzheimer's disease pathology, that there are other etiologies that are causing their cognitive impairment. However, this does leave this intermediate range, and that accounts for about 15 to 20% of patients. Many of these patients may have very low levels of Alzheimer's disease pathology. Some of these may be false positives or false negatives if you were to use a single cutoff. So, for those patients who have a result in the intermediate range, what we recommend doing is individualizing the next step. So, if you are, for example, evaluating a patient that you're considering for amyloid targeted treatments, and you want to know and you need to know quickly whether they do, in fact, have amyloid pathology or not, then in that patient, I would send them for a CSF test or a PET scan right away. However, imagine that you have a patient where there's a lot of uncertainty about their diagnosis. You're not necessarily going to change their immediate management. It was more just trying to help you understand a little bit better what the causes of their cognitive impairment are. If it's not urgent, you can wait and do a test later, or maybe not even retest them. So it really depends on what the implications are of the result, what the next step is. Um, but overall, we find that this kind of two cutoff approach is really quite helpful in increasing our diagnostic certainty and also identifying individuals who would benefit from a second test. Now, there are two general ways to use blood biomarker tests. If you have a test that's highly sensitive, greater than 90% sensitive, but maybe has a lower specificity, such as 75% or maybe higher, you can use this as a triaging test. And what this means is that if the test result is negative, the patient is very unlikely to have amyloid pathology because, again, this was a highly sensitive test. So if the test is negative, you're done. You have ruled out amyloid pathology. However, if the test is positive, the patient is more likely to have amyloid pathology, but it's not certain because the test is not that specific. So, in this patient, if they have a positive result with this type of test, you want to perform a second test, typically a CSF test or an amyloid PET scan to confirm whether or not they have amyloid pathology or not. Now, there's a second way to use these blood biomarker tests. If you have a test that has both very high sensitivity and specificity, greater than 90% for both, then you can use this as what we call a confirmatory test. And these sensitivity and specificity limits were set because this is what we achieve with FDA approved CSF tests. This is about their performance. So in this case, a negative test identifies individuals who are unlikely to have amyloid pathology, and you don't need another test. And a positive test identifies individuals who are likely to have amyloid pathology. And because the test is highly specific, in this patient, you do not have to perform another test to confirm the presence of amyloid pathology. And this is particularly true when you start with a patient who is, before you even do the test, likely to have amyloid pathology, a high uh, pre-test probability, because in that patient, if you have a test with greater than 90% sensitivity and specificity, they have a very high positive predictive value, and it's extremely likely that they have amyloid pathology based on both their pretest probability and the results of the blood biomarker test. One thing that is somewhat difficult for providers to sometimes think about is that the same test can have a different meaning or a different level of certainty in different types of patients. And this is because of this pretest probability. In other words, the likelihood that someone has Alzheimer's disease pathology even before you do the test. So I think it's helpful to think about this in terms of patient cases. So imagine that you have a 75-year-old patient with a typical AD dementia syndrome. We know from a variety of studies that they have a very high pretest probability of amyloid pathology, maybe around 85%. So before you even do a blood test, you would expect that 85% of these individuals have amyloid pathology. And if you have a biomarker test with 90% sensitivity and specificity, and this result is positive in this patient with a pretest probability of 85%, when you run the statistics, and look at the probabilities, 98% of these patients are true positive. So if in this patient they have a positive test result, you can really have high confidence that they are in fact amyloid positive. On the other hand, in this exact patient with this exact test, if the result is negative, there's a significant risk that it could be false negative. So about 39% of patients would have a false negative result. So you have to be a little bit skeptical about a negative result in this patient. Now, let's talk about the same test, but in a different patient. So this is a 60-year-old patient with subjective cognitive decline. A variety of studies have suggested that the prevalence of amyloid pathology in this patient would be about 20%. Now, in this patient, if they have a negative result on this blood test, you can have high certainty that the patient does not have amyloid pathology, so you can rule them out. However, in this same patient, same test, if they have a positive result, there is a significant risk that it could be false positive. So, this is generally a little bit challenging to think about, but one way that I've heard this articulated when I was in medical school was you have to treat the patient and not the test. And if the test results are not really aligning with your clinical suspicion, then you need to look further. So I think this is generally an important lesson, and if you do have test results that don't align with your clinical suspicion, I would recommend doing a further clinical evaluation, maybe further testing, and maybe further biomarker testing until you really have confidence that the results are correct and you have a clear assessment of what's going on with the patient. Now, thinking about the performance of these blood tests and which blood tests to use, and also about this concept of what is the pretest probability, what's the positive predictive value, negative predictive value, these are challenging concepts to think about. So, we have developed tools to help clinicians to get information about this. One of these tools is the Alzheimer's Disease Blood Test Performance Database. And so you can go to this website to look at the performance of various blood tests and think about whether this test is appropriate for clinical use. This database compares the performance of these tests to established standards for blood tests. Another tool is this website that you can go to where you can put in a patient's age or other variables to think about what their positive and negative predictive value is for various types of blood tests. Again, this helps you to think about how certain am I that this blood test is correct, or do I need to look further? Before we move on, please take a moment to answer a follow up question on biomarker testing.
So, what are our take home messages? Well, it seems increasingly that blood based biomarkers are ready for application in primary and specialty care settings. p-tau 217 tests alone or in combination with some other biomarkers are the most accurate blood-based biomarkers with increasing clinical applications in patients who have symptoms of impairment that we think is due to Alzheimer's disease. Multiple blood tests based on p-tau 217 show similar accuracy to spinal fluid tests and are clinically available through a lab near you now. But proper implementation of blood-based biomarkers requires an understanding of what these tests can and, just as importantly, cannot do. And I'll emphasize that blood-based biomarkers cannot confirm that Alzheimer's disease is the cause of a patient's cognitive decline. This is especially true in older patients who may have additional co-pathologies like cerebrovascular disease or Lewy bodies from the alpha-synuclein proteins, or in patients with atypical clinical presentations where other possibilities simply may be a little bit more likely. Taken all together, though, this underscores the importance of only ordering blood-based biomarker tests for patients as a part of a comprehensive cognitive evaluation in someone who we've already obtained a history, physical examination, and other supportive measures that demonstrate that impairment. And we are going to interpret these tests in conjunction with other important clinical metrics that help us to interpret the test results when we get them. At a minimum, that's going to include chronic kidney disease and maybe other diagnostic tests as well that can reinforce our expected etiologic cause of cognitive impairment in our patients.
So, thank you so much for joining us today for this presentation. Greg, thank you so much for this excellent discussion about blood based biomarker testing in Alzheimer's.
Thanks, Suzanne. It's been a real pleasure.
The next workshop in the series will air on January 20th, 2026 from 7 to 7:30 p.m. Eastern Time, where I'll be joined by Dr. Hamid Okravi to discuss the latest scientific and regulatory developments that are shaping the use of blood-based biomarkers in clinical practice. You can visit the Alzheimer's Disease Biomarkers Learning Center at this web address for helpful clinical resources on diagnostic biomarker testing for Alzheimer's disease. After the session concludes, visit peerreview.com to claim credit and access the activity materials. Stay tuned for the online activity based on this event. Thanks again for joining us.